Hello and welcome to our video on how best to care for patients with decompensated liver cirrhosis. I am Dr. Jamie Willows.
And I'm Dr. Alice Wheatley.
And I'm Dr. Simon Cowlam, consultant gastroenterologist.
Over the next 10 minutes, we hope to remind you that decompensated liver cirrhosis is a common medical emergency which frequently presents to the front of house, and to introduce and encourage the use of the Decompensated Cirrhosis Care Bundle, which can be found on V6 Meditech and is a useful guide to the management of these patients.
What we know so far is that the management of patients with decompensated cirrhosis has historically been suboptimal, both on a national and a regional scale. There is evolving evidence that guideline-based management of these complicated patients improves care. Also, that early intervention during the patient's admission is critical to maximising their chances of a good outcome.
This video is aimed at all members of the MDT who encounter patients with liver cirrhosis in their daily practice, be it at admitting doctors to nurses and nurse practitioners. So let's recap what decompensated cirrhosis means. Decompensation is essentially a deterioration in liver function. Decompensation can manifest in a number of ways, including jaundice, increase in ascites, hepatic encephalopathy, renal impairment or hypopholemia, signs of sepsis.
We can determine whether a patient has a diagnosis of cirrhosis through review of their old notes, previous clinic letters via Meditech, or by review of historical imaging reports. However, you may be the first person to pick up a potential diagnosis of cirrhosis, and this can be elicited by assessing risk, such as alcohol excess, their examination findings, such as spider nevi or ascites, or their blood tests, namely low platelets, high prothrombin time, high bilirubin, low albumin, or deranged liver enzymes.
However, decompensated liver cirrhosis is never the only diagnosis to make. You need to consider the cause of the decompensation. Common and serious causes we should consider on assessment at front of house include GI bleeding, renal impairment, and infection, such as spontaneous bacterial peritonitis, the management of which will be covered later in this presentation. Other causes may be elicited from the patient's history, for example, any new medication, recent alcohol binges, or constipation. Some causes may be picked up by investigation back of house, such as a portal vein thrombosis or an HCC diagnosed on ultrasound.
The Decompensated Cirrhosis Care Bundle arose after a national inquiry in 2013 into care for this patient group. This indicated that less than 50% received what they called good care. You may wonder whether this applies in the Northeast too. And well, yes, an audit of over 100 patients across the Northeast in 2013 showed that 1 in 5 patients with variceal bleeding didn't receive terlipressin. Almost 2/5 of patients didn't receive an acidic tap within 24 hours, despite them being at risk of spontaneous bacterial peritonitis. And over a quarter of patients with AKI did not have their nephrotoxics stopped.
In response to suboptimal care, the Cirrhosis Care Bundle was produced and implemented by the BSG as gold standard. And many sites have introduced it as a toolkit to remind practitioners of the management points to be considered in these patients, no matter what their cause of liver cirrhosis. In Sunderland, the bundle is electronic and should be used as soon as possible during a patient's admission. It should be used in patients with known or suspected liver cirrhosis of any cause. The bundle can be found in documents under D for decompensation. The fact that it is between death certificate and departmental M&M review may help you to remember this, both things we aim to avoid through the early implementation of the bundle. From there you begin to review and complete the bundle. This can be started in A&E, saved as a draft and picked up and completed when the patient is transferred back of house. We will now go through the bundle step by step.
Firstly, it highlights the investigations that patients with liver decompensation require to assess the severity of the decompensation and screen for the cause, for example, renal impairment, electrolyte disturbance, bleeding, or sepsis. As a rule of thumb, we recommend front of house gets an ultrasound requested early, if one has not been done in the last month, to screen for portal vein thrombosis or HCC. The results can then be chased back of house.
Please note that a repeat liver screen with tests such as ferritin and ceruloplasmin is not required in a patient with known cirrhosis.
In addition, testing ammonia levels is not required as hepatic encephalopathy is a clinical diagnosis and ammonia levels do not correlate well with the severity of encephalopathy. This also saves you having to find some ice to put the test in. Next, an alcohol history is taken, including when the patient had their last drink and whether they have had an alcohol-related seizure in the past. This will remind you to prescribe Siwa and Pabrinex. We know that an appreciation of alcohol history is important, as in the Northeast, 80% of cirrhosis is due to alcohol, with a significant proportion of patients still drinking and therefore being at risk of withdrawal. Pabrinex given at a dose of 2 pairs 3 times a day in patients who continue to drink is a treatment which helps prevent the life-changing condition of Korsakoff's syndrome. Also consider referral to the Alcohol Liaison Service.
The next section is further prompting investigation for infection and sepsis. This is of great importance due to the fact that patients with liver cirrhosis are at high risk of bacterial infections as a result of their low immune status. Infection and sepsis is the leading cause of death in these patients. Patients with liver cirrhosis commonly present with infections at the usual sites, such as urinary and chest. However, they may not show classical biochemical signs of sepsis, such as raised white count or the physical signs such as pyrexia. Importantly, we also need to think about spontaneous bacterial peritonitis, SBP.
SBP is the presence of bacteria in the acidic fluid without a secondary reason for them being there, such as bowel perforation. It may present with the features of abdominal pain, fever, or encephalopathy. However, it is asymptomatic in roughly 1/3 of cases. The only indicator for SBP in these asymptomatic patients is the non-specific deterioration in liver function seen biochemically and on examination. There is a strong argument that if you are taking a blood test from a decompensated patient in A&E, you should be performing an acidic tap to screen them for SBP at the same time. The risk-benefit ratio of having an acidic tap is such that the BSG recommend it should be performed whatever the platelet count or prothrombin time. The fluid is put into a white specimen pot as well as a pair of blood culture bottles and sent to the lab along with the fluid protein request. There is a specific order set for this on Meditech. The patient is treated for SBP if the neutrophil count in their acidic fluid is greater than 250 mm³, with not only IV antibiotics, but also IV albumin, as highlighted in the bundle.
We are hoping that more acidic taps will be done in the emergency department for several reasons. Evidence shows that early taps are the best opportunity to grow specific organisms. Any delay in correct antibiotics for SBP and IV albumin is associated with increased mortality. Proving a diagnosis of SBP is better practice than just covering for it. Remember, a formal diagnosis of SBP is an indication for prophylactic long-term antibiotics and sometimes an indication to refer for transplant assessment. Antibiotic stewardship means that we should try hard to use antibiotics only where clinically indicated. Due to proficiency with ultrasound, the emergency department may be the perfect place to perform acidic tabs in cases where the fluid is not easily identifiable by percussion alone. The earlier we obtain the acidic fluid, the better it is for the patient. So, if you're not confident in performing a diagnostic tab, please discuss it with your senior.
The bundle then discusses what should be done in the context of an acute kidney injury. Common misconceptions here include:
1.
Firstly, normal saline will exacerbate and worsen a patient's ascites, and so can't receive crystalloids. Actually, these patients need to be fluid resuscitated in the same way you would resuscitate any patient with pre-renal AKI. These patients are fluid deplete, and so front of house they can have several litres of normal saline until euvolemic, just like any other dehydrated patient.
2.
Another common misconception is that patients with ascites must continue diuretics despite new renal dysfunction. Again, as with other patients with AKI, they need to have their nephrotoxics stopped.
3.
Finally, be hesitant of making a diagnosis of hepatorenal syndrome front of house. Yes, their renal dysfunction often could be due to HRS, but this diagnosis can only be made after the patient is reviewed with repeat bloods, once euvolemic and off the diuretic. Therefore, a diagnosis of hepatorenal syndrome should be made back of house under the gastroenterologist.
The next section looks at GI bleeding as a cause for decompensation and how to manage it. Given the high mortality of GI bleeds in these patients, the key point is to suspect bleeding as varicose if there's any evidence of bleeding in the cirrhotic patient. The bundle helps us to effectively manage suspected GI bleeds with prophylactic IV antibiotics, a practice with a good evidence base to decrease mortality, rebleeding and length of stay. Prophylactic IV antibiotics in varicose bleed has a number needed to treat of 4 to prevent one clinically significant infection. Terlipressin should be given as this is an effective treatment to decrease blood loss from varices, though caution should be used in all patients with ischemic heart disease or peripheral vascular disease or over 65 years old due to risk of ischemia, and patients should have an ECG first. Discussion with specialties is highlighted, namely gastroenterology to consider OGD, and haematology if their platelet or clotting abnormalities warrant further correction beyond IV vitamin K.
Following on from GI bleeding as a cause of decompensation, the bundle asks you to consider if encephalopathy is present, and if so, what its underlying cause could be. We know that as a patient group there is the risk of falls, and in the context of low platelets, a huge bleeding risk, and so suspect other potential diagnoses like subdurals, thus considering the role for CT head in the confused patient with known liver cirrhosis. In terms of the treatment and prophylaxis of encephalopathy, the bundle advises the use of lactulose with the aim of 2 soft stool motions a day. Lactulose is a very safe and effective drug, which decreases bowel pH and decreases encephalopathy through alteration in the gut microbiome.
The risks of venous thromboembolism are considered next. This is an area filled with myths and misconceptions.
The high PT means they shouldn't give dalteparin, right?
Don't they auto-anticoagulate?
Studies show that you cannot predict the patient's bleeding risk in cirrhosis from the prothrombin time alone. Whilst the high PT tells you that the liver synthetic function is poor and not producing enough clotting factors, what you don't see is that the cirrhotic patient is also not metabolizing clotting factors. This shifts the balance in decompensated cirrhotic patients towards being prothrombotic and having a higher risk of thromboembolism. So, to reduce the risk of DVT, it is recommended that patients receive the usual prophylactic dalteparin dose as long as their platelet count is over 50 and bleeding is not suspected. Finally, the bundle then finishes with a reminder to hand over the patients to the gastroenterology team.
So to recap, in the past, in our region, 1 in 5 patients with varicose bleeding didn't receive terlipressin, 40% of patients didn't receive an acidic tap despite being at risk of SBP, and over a quarter of AKI and cirrhosis patients did not have their nephrotoxics stopped. We think we should be aiming to give better care than this at Sunderland, and you can help to give the care these patients need.
To conclude, work in front of house, you will see decompensated liver disease. There is a lot to remember to do when managing these patients, but remember the bundle is on Meditech, documents under D for decompensated. The bundle helps us to give the best care when managing the medical emergency of decompensated cirrhosis. And remember, your early interventions at the beginning of a commission are critical.
So, I have been Dr. Jamie Willows.
I have been Dr. Alice Wiedner.
And I've been Dr. Simon Cowler. Please get in touch by email if you have any questions or would like further information. Thanks for watching.